Okay. So we would like to acknowledge that the land we live, work, learn, and commune on is the original homelands of many tribal nations. We acknowledge the painful history of genocide and forced removal from this territory. And we honor and respect the many diverse indigenous peoples still connected to this land on which we gather. Now, we also want to do a labor acknowledgement that we must acknowledge that much of what we know of this country today, including its cultural, economic growth, and development throughout history and across time, has been made possible by the labor of enslaved Africans and their ascendants, who suffered the horror of the transatlantic trafficking of their people. The chattel slavery and Jim Crow, we are indebted to their labor and their sacrifice, and we must acknowledge the tremors of that violence throughout the generations and the resulting impact that can still be felt and witnessed today. So at this time now, I'm going to turn it over to, I'm going to stop sharing my screen, and I'm going to let Katie and Mark share their screen and go through some information on ACC Phase 3. So Katie, I know I saw you on, but I didn't see Mark yet.
I am here this morning, and I'm sorry to anyone if we got your hopes up about Mark being here. He has a conflict, so it's just me. Dana, could you please enable screen sharing for me?
Yes, give me one. I'm gonna make you a
Thank
host.
you.
Let me just find you. Okay, let me know if that works.
Perfect. It looks like that worked. All right. Good morning. Thank you, everyone, for letting us join today, or I guess just me. Again, Mark is not here. Letting me join today to share a little bit about ACC Phase 3. My name is Katie Lenigro. I work as part of the Accountable Care Collaborative Delivery System Division. And I see a lot of familiar faces. So as you know, I've been supporting a lot of our stakeholder engagement as we've released the concept paper. So today, I know that many of you are very involved with the Accountable Care Collaborative, but for those who may not be, I just wanted to briefly cover some details about this program before we get into what Phase 3 is. So the Accountable Care Collaborative, we refer to that as ACC because it can be a bit of a mouthful. It delivers cost-effective quality healthcare services to Health First Colorado members to improve the health of Coloradans. This is done through the coordination of regional, physical, and behavioral healthcare services to ensure member access to care. And that regional coordination is done through the regional accountable entities, and they help members by coordinating care with different providers, arranging behavioral health services. If a member needs help finding a different provider, providing that kind of support, helping with referral processes, and working with community groups. And so this map shows the current regional accountable entities in what we call Phase 2 of the Accountable Care Collaborative. So there are 7 regions in Colorado with 5 different organizations managing the services in those regions. And while regional accountable entities are primarily focused on supporting our members with their physical and behavioral health care, they also have many other responsibilities, more on the administrative side as they support providers. So that's contracting with a network of primary care medical providers. And these are the providers that serve as a focal point of care for our members, arranging behavioral health care services, and just generally helping with coordination and administrative support for providers. So with that, we are spending a lot of time talking about Phase 3 in many different forums. Phase 3 is really referring to the next round of contracts with vendors, which would begin on July 1st, 2025. And leading up to that implementation, we are looking at how to improve our program for members and providers. So these are the overarching goals for phase 3, and they really align with the goals here at HCPF. They are to improve quality care for members, close health disparities and promote health equity for members, improve care access for members, improve the member and provider experience, and manage costs to protect member coverage, benefits, and provider reimbursements. Within these goals, there are a number of proposals that are outlined in our phase 3 concept paper, which is available on our website, and I can share some of those links in the chat for everybody after this. Most relevant today is our second goal of closing health disparities and promoting health equity. And we do have some proposals around that. They're probably very familiar to everyone in this group. Aaron here at the department has really led our phase 3 health equity work, and I have a feeling he's probably shared this with you, or you have helped inform some of these proposals. But if you're seeing this for the first time, we're proposing that we continue to address regional health disparities by requiring each of the regional accountable entities to create their own equity plans. We want to make sure that the regional accountable entities understand and are addressing the unique needs of their regions and communities. We want to add a key personnel position. So there are a handful of these positions that are outlined in the regional accountable entity contracts. This would be a key personnel position that would be point on all of the health equity work that is happening within that regional accountable entity. And then HCPF is working on a number of health equity trainings that these regional accountable entities would be required to complete. And then we would require that each region has an equity task force that's made up of providers, members, other community partners in their region. And the goal of that task force is really to ground the work of the regional accountable entity in the needs of their communities. So I know I went through that pretty quickly, but really what I'm hoping to get some feedback on today, which I know we don't have a lot of time, so I'll share some contact information and ways to share feedback later, is on our current stakeholder engagement work. So a lot of the recommendations for phase 3 have been informed by the feedback we've received from stakeholders. Many of you on this call have helped inform what is in the phase 3 concept paper right now. And we still have many opportunities for stakeholders to be involved leading up to the go live of phase 3. So what we have been doing so far, in addition to hosting our own public meetings, we regularly meet with the Accountable Care Collaborative Program Improvement Advisory Committee. And there are 3 subcommittees as part of that too, that focus on behavioral health integration strategies, provider and community experience, and performance management and member engagement. And these committees are really made up of providers, there are member representatives, and other community partners. We also meet with the regional program, the regional program improvement advisory committees and their member councils that are hosted by all of the current RAIs. And then we regularly join other HCPF stakeholder meetings, such as like the Member Experience Advisory Council. We're meeting with the county directors next week. We do try our best to meet with a variety of stakeholders, especially because we know everybody has varying experiences with our program and the healthcare system, but I think there's always room for improvement. So what we're hoping to get feedback on is who else should we be engaging that maybe we haven't been yet. And so I can pause in case anybody has any immediate thoughts, but there will also be, I'll share my email address and some other ways to provide feedback if you have ideas of who we can be connected to. All right, in case people are thinking, I'll just move on, but please feel free to add any thoughts to the chat or reach out to me after this. But as mentioned, here is our timeline of current stakeholder activities. And while we've already held quite a few stakeholder sessions leading up to posting our concept paper, and just recently to get feedback on our concept paper, we will continue to engage with stakeholders, especially leading up to the release of our request for proposal. So there's still a lot of opportunity for people to provide input, and we just want to make sure that we give people that opportunity. So as mentioned, there are ways to provide feedback. So if you haven't seen it yet, we do have the full concept paper on our webpage. And there is an online survey specifically to provide feedback on the concept paper. Those responses do populate a publicly available spreadsheet, and that names won't be shared. It's not like a way to deter people. It's just our way to provide transparency so that stakeholders can see what feedback we've received on the concept paper so far. And maybe it is helpful for folks to read that, and it might, jog your brain, and maybe you'll think of some feedback too after reading those responses. If you have other feedback on just general like phase 3, like stakeholder engagement sessions, general questions for us, we do have an open feedback form that is always available on our website. This concept paper survey will close at the end of October. And then if you haven't joined one of our public meetings yet, we do have 2 more coming up next week, one for providers on Tuesday morning, and then one for members only on Thursday evening, I guess. And then again, please, I would love to hear from you if you have ideas on groups that we should be reaching out to. Maybe you represent a group that we haven't met with yet and you think that we should. Please feel free to reach out to me or complete one of those surveys with that information, and we'd be happy to figure out what we can do to get connected. So I'll stop sharing and see if anyone has any thoughts. But thank you again for letting us join this morning.
Thank you, Katie. It looks like there was a request for the link to the concept paper. If you could put that in the chat, that would be great.
Absolutely. I'm getting some links now, and look out for those in a second.
And are there any questions for Katie? She did share her email address. If not, you can always reach me and I can get you connected with Katie if you have any questions that come up later. Okay, well, if there's no questions for Katie at this time, thank you, Katie, for joining us today. And thanks for sharing information. And again, if questions come up for anyone, you can reach out to Katie or you can reach out to myself, and we'll make sure to get you connected and get your questions answered. Or if you have groups or organizations that they should be reaching out to, we'll make sure that Katie gets that information. And I am going to reshare my screen. And we will continue on with our presentation. So today, one of our co-chairs, Diane Findley, who is a buy-in member, was going to present on advanced language access and health literacy and the provision of culturally tailored services. She had a conflict. She's attending a conference. She was going to try and join, but I don't think I saw her on. So I told her I would present the information for her. So we'll go through this information, and it's actually, as we continue on with our CMS priorities, this is priority number 4 in the CMS priority information. So priority 4 is advanced language access, health literacy, and the provision of culturally tailored services. And CMS has indicated that they must ensure that all individuals, including members of communities that are underserved, can equitably access all of CMS's benefits, their services, and supports and coverage. Language access and health literacy and the provision of culturally tailored services play an important role, as we know, in health care quality. Effective communication is critical to ensure understanding, empowering patients, and providing high-quality care. A language access plan can help ensure that organizations provide high-quality and appropriate language services. So what is a language access plan? The language access plan spells out how to provide services to those who are non-English speaking or who have limited English proficiency. The plan should be tailored to who your organization serves. So there's not a one-size-fits-all plan. The plan should be tailored to your organization and who you serve and meet the needs of your consumers. Oops. So this slide talks about the steps to create a language access plan. So you first need to do a needs assessment. So you look at how many individuals will the services will need to access the services. Where will they access the services, and how are your consumers or the individuals interacting with your organization? Are they coming into your organization in person? Do they do a lot of contact virtually? Is it over the phone? So you just need to determine how they're accessing and interacting with your organization. Then you look at your language services. So this is going to be the description and type of services the organization will provide. So will you have interpreters? Will this be in person? Will it be virtual? Will you have translation or documents that are translated into the languages that's needed for your organization? So you just need to kind of determine the services and the language services that are needed. And then notices. How will you let the consumers know about these services? How will you let individuals know that you have various language access services? So will there be flyers, posters? Is there going to be a message on your website? Are there messages on your phone system letting individuals know that these services are available? And then training. How are you going to train your staff on these language assistance services? Or are you going to have a point person or two individuals that will take this information on that staff will be able to direct to the individuals in your office that are handling any language access services? And then evaluation. How and when are you going to monitor? If you need to update, if you need to add some additional services, or if you realize the service is not being utilized, do you need to modify? So that's just kind of the steps to a language access plan. So in 2020, the health literacy definition was updated, and the updates address personal health literacy and the organizational health literacy. And so the new definitions emphasize people's ability to use health information rather than just understanding the information. And it focuses on the ability to make well-informed decisions rather than appropriate ones. And you acknowledge that the organizations have a responsibility to address health literacy and then to incorporate a public health perspective. So that's just kind of the update of the definition of the health literacy that CMS updated. So using health literacy best practices can build trust and help advance health equity. And we know that trust is a key part in an individual's willingness to engage in healthcare. And so some key recommendations for health literacy are: make sure you're using plain language, and you want to make sure that you're using your audience's preferred language and communication channels. So again, it's going to be different for everyone. for your consumers, for your individuals that are coming to use your services. You want to make sure that you're using preferred language and the communication channels that will assist the individuals that you're serving. And then make sure that you're using culturally and linguistically appropriate language. Reviewing and changing the structure of a program or practice to more appropriately fit the needs and preferences of a particular cultural or group. So as the graphic shows on the slide, we can see that everything is interconnected, and the importance of making sure that the health literacy and the language is included and part of the service. So just kind of making sure that your services, your language access, and all the service you provide are culturally tailored to those that are coming to your services, that are requesting your services, and those that you serve. And I think that is the last slide. So our next, we'll open it up for some questions. But this is going to be our action items for our work groups. And before I get into this information, I'm going to open it up to see if we have any questions or comments just on the information that I just shared. And I see some hands raised and I can't see Jeanette.
Yeah, thank you so much. I took some notes, and I used to be a Medicare national broker. So I love CMS. I'm really happy they're bringing this forward. I've thought for a while that customization of services would be cheaper than broad range services. So if there was a way to provide for the individual, yeah, the agency can have everything in place in case it fails, right? But I need book on tape. I can drive, but I need special glasses that are expensive and stuff. So if I was provided what I needed and I could bring it to the agency with me, then no matter where I go in public, I would be cared for, and it's customized. We're spending, you know what I'm saying? We got the 711. Yeah, we got this 711 number and the translation and stuff, but I just watched a TED talk about somebody, or no, she was in a high school, and she used sign language and needed to dial 911. And it didn't work. And so they got a special project in New Mexico. I thought that was worth bringing up. And then when it comes to CMS, they hold a lot of hands and they contract out to for-profit vendors. And so I personally had an issue caring for my dad when it came to it was private Medicare supplement versus Medicare Advantage. And UHC, and CMS, they didn't hold hands about it. So for example, oh no, this was a different client. Here's the example. She fell off her bike and crushed her jaw, and then transferred from private insurance to Social Security Medicare benefits, and had a supplement and couldn't get care. There wasn't doctors on the list, but of course with Medicare Advantage there was. And it was just a struggle. It ended up being a really bad situation for the client, and I couldn't really get answers for her. So I think sometimes when we're looking at this language, it would be nice to bridge the gaps between agencies, build that in somehow, and then customize the adaptiveness to the person. Thank you.
Thank you, Jeanette. Great points. And I think that kind of leads us into our work groups, because I think that's something that you can share within your work groups as you're starting to talk about your recommendations. And then I see two more hands raised, and I can't see who they are.
One
there.
Jeanette.
Okay.
Yeah. So Jeanette, I appreciate you mentioning that. Yesterday, I was on the HICPUF chat with the disability population, and I had brought up giving service access for those who need, ASL. They can turn it on whenever they need to, instead of, relying on the entities. But it would be a service provided through, your plan. So I appreciate your voice there. But I just was wondering about specifically around the health literacy, and if there is anything in HICPUF that discusses kind of what the health literacy guidelines are for that HICPUF applies for their stuff. Just to kind of carry it down. So like CMS, and then does HICPUF have its own kind of guidelines that maybe we can pull off of? So just was wondering.
Yes, thank you, Sarah. We're working on that. We haven't really flushed everything out yet, but that is something that we're working on, and something that we will make sure that we have available, and we'll just let everyone know when we have that available. But yes, that is something that we are working on. Okay, so now we're just going to talk about our work groups. So the action item for your work groups, please discuss your top tactics or your ideas to improve what we talked about today: the advanced language access, health literacy, and or provision of culturally tailored service. So you can, do all three or all, pick one. What we want you all to do in your groups is to begin to formalize your recommendations for the department. We're getting kind of close to the end where we're going to start needing to get the formal recommendations. So we have a meeting, which was technically our last meeting, is scheduled for November 30th, but I think we're going to end up going into the new year, at least one more meeting after that, November 30th. But by November 30th, we're asking that you kind of have all of your recommendations that you want to put forth. We'll look at it as the task force before we vote on which ones go to the department. So we want to have those in by November 30th. And then sometime after the new year, January, February, you'll come back, you'll present it to the task force, and then we'll kind of take a vote on which recommendations go forward to the department in a formalized setting. I'm going to put a link in chat in just a sec of all the links for each group. And I added a form in each group's folder, a recommendation form, so you can kind of start writing down and formalizing your actual recommendations. So I'm going to do that. So when you go into your groups, you'll have that form, so you can take everything that we've talked about these last few months, incorporate all of the CMS priorities that we've talked about so far, and start really thinking about which recommendations out of your focus area that you would like to present to the task force of a recommendation for the department. So I'm going to put in the links to all the things. If you give me just a sec. Just give me one moment. Okay, so I think I got them all listed in there, so she be able to access each group. And so in the main room, I'm gonna have the vaccinations, COVID-19 stay in the main room. And I will also have the interpreters stay in the main room. If anyone is using that services, you're gonna go with the vaccination COVID-19 group. Breakout room 1 will be maternity. Breakout room 2 will be access to care. Breakout room 3 will be behavioral health. And room 4 will be prevention. So I'm gonna start the rooms now. We'll have about 30 minutes for you guys to go in and start working on your recommendations and your discussion. And then we'll come back and we'll share out. So I'm gonna open the rooms now. And again, the main room, the vaccination group will stay in the main room along with the interpreters. And so go forth and pick your room. And again, main room is vaccination. Room 1 will be maternity. Room 2 is access to care. Room 3 is behavioral health. And room 4 is prevention. So I think you all that are in the main room, which is vaccinations and COVID-19, you all can go ahead and get started. And I'm gonna bounce around to the different rooms, so I'll be kind of back and forth.
Hello. I don't see, are the COVID folks? I think Sophia, you've been in our group before. I'm trying to look at all the folks still in this room, just wondering if everyone's here, if we can get started or not.
Yeah, I'm not seeing too many familiar names from previous conversations other than you. Jason, I think you've been in
Yeah,
our group before too, right?
Correct.
yeah. Hi, Jason. I wonder if any others are going to be joining in.
It looks like this might be it. It looks like everyone else is gone to another room. So I think this might be it for the vaccination group. You might have to do a quick, get everybody up to speed. That hasn't been part of the group yet, but feel free to get started.
Great. Maybe the easiest thing to do first is I can share my screen and go through the work group focus areas document that we've been adding to. And then Kaylin, I don't know what your thoughts are.
Yeah, I think that's a great place to start. I don't know what, yeah, I think we should just start there.
Actually, I don't know if I'm going to be able to share my screen. Here, let me just put the link in the chat to the document. And it should also have been included in when you access the Google Drive for the COVID group that Dana put into the chat as well. But if you click on that Google document, essentially, I think that has just some notes from our previous meetings. And just really quickly walking through it, some of our priority populations that we've talked through is our pediatric members, 11 and under, especially related to more routine vaccinations, our unhoused population, and also just some of the struggles with data collection and really being able to identify our unhoused members, Latino and other immigrant communities, Black and African American communities, American Indian and Alaska Native, and then our rural populations. Some of the solutions that we talked through is normalizing the COVID vaccine by including it in routine visits. So instead of having it just be a kind of a off by itself type of thing, just making that part of that overall package of an overall messaging, just like how the flu shots are integrated into that. We've talked about the structural system and the importance of providers matching the identity of the communities that they're serving, holding providers more accountable, ensuring that pediatricians are having conversations at time of well visit. So one of the things I think we've seen in the data too related to well visits and vaccines is that when comparing the number of pediatric members that are accessing a well visit and at the time of well visit, if they were eligible for the vaccine, didn't receive it. And so just making sure to normalize those conversations since they are already in the pediatrician's office. Community investments that we talk through are really
just that document called, it really explains the whole structure of the Health Equity Task Force. Really, the name escapes me.
Okay, thank you so much.
Yeah.
Was everyone able to open that form? The recommendation form?
This is Renee. I cannot, with the security for my organization, we can't open anything Google. And
Okay.
so I forwarded it to my personal, but it won't let me open it because I forwarded it. So I cannot open it.
If only we all thought it was 2023 and this would be easy.
I know. Well, and Google Docs are easy to read. It's
right.
You know, for a voice screen reader, but not with the securities we have on our
with your system. Yeah. Okay. Well, I'm happy to type if that's helpful.
Yeah.
Since we do live in Google at the state, so I can type, so everyone else doesn't have to think about trying to access it.
Yeah, perfect.
We're so essential in educating people. I'm thinking particularly of like farm workers about COVID, and helping. They were part of the vaccination campaign, and they were essential in getting PPE and other essential items. And I just think that community health workers, which include doulas and possibly midwives, that they really lead the work in not only like health literacy, but also I would even say, well, I'll stop there for now. But what I'm thinking, and my thought is kind of fuzzy, is
addressed so that it's sufficient to do that and to do a good job with it, maybe sufficient to provide when you're providing a written document afterward, like an evaluation, maybe that has to be in multiple languages, and that takes a lot more time too. So the goals can't happen unless there's enough compensation for it. And I was also thinking about what Elisa said. I think one of the reasons that people ask a Spanish speaker to serve for any Spanish speaker is because there are not enough people. Because it's hard to enter the labor force in those jobs, and it's not compensated enough. So somebody from Puerto Rico.
It's really important to honestly be able to get that identification and get that advocacy and agency from a provider, hopefully, that can identify these needs for accommodation, just through not necessarily coming in for a problem, but encouraging people to come in to just discuss maybe their healthcare questions and get screened for things that could easily be
Yeah, we appreciate the opportunity. I think, Sophia, as we talk, I think we could just dive into language. I wish Julissa Soto was with us today because she is very experienced in transcreation, what she
Yeah.
translation, or what she's termed for her translation services, which are very much more than what we would historically have considered simple sort of translation services, and very much more equity centered, health literacy focused, culturally competent, and I think that is most definitely a best practice, and she has really good stories and information across the state where it's really worked getting people especially engaged in vaccination efforts.
Yeah, I was thinking the exact same thing when I looked at this is what our auditor is going to be using. This is what our friends at Colorado Access use, and I think it would give us just a nice starting point to know that, like, okay, everybody's on the same tool, same platform, maybe running into the same things.
Oh, that's a good idea. Like a kind of sharing of best practice and best tools among all of our organizations. That's a great idea. I can bring this to our community of practice and see what everyone thinks.
I just wanted to pop in because Dana's in here, but Dana, we can't screen share in the room. So if you could turn on the ability, that'd be great.
Let me see if I can do that for you.
Okay, I'm just going to go back into my room. Sorry to interrupt.
So I'm also taking notes on this stuff, Katie, in the work group focus area, access to care, just like on the bottom page of other notes we've had. So we're not losing any of these ideas. Just so you'll know.
Perfect.
Is advanced language access? I don't think ensuring that all individuals we serve, including members of communities that are underserved, can equitably access all CMS benefits, services, and other supports and coverage. I don't know if there's actually if there was a definition. Dana, we were looking for specifically what HCPF defines as advanced language access over a regular language access, or if that's just language access is language access.
I think it's just language access is language access, because I hadn't seen anything, specific to advanced language access. So I'm just going with language access.
Okay.
And I'm
So it's nothing different.
giving you, I can't give you access to share, and I don't know why.
I think it's a setting. It's no problem. I was just reading actually what they were saying, but that's not a problem. Thank you though for trying.
Sorry.
Appreciate it. And then, and Jeanette, you were saying that it would be nice to see that, you know, small business owners and like kind of for the employment side, that they offer these things up front, or they have the ability to get access to, you know, obviously funding to provide these services for their employees. Accommodations really.
Yeah, I think it's too much to bear, honestly, for a small business in some
Yeah.
ways.
I would
And
agree.
big agencies, you got to have an IT department, and they're not necessarily, you know, the people who are ADA or equity, diversity, and inclusion people. They're tech people. You know, I think agencies need to hold hands better. I worked with Voc Rehab. I asked them to sponsor me a Grammarly subscription, and I had to tell him what Grammarly was. He didn't know, and he's my case manager. So convincing employees of the services I need, and they're in a position to, I think you guys need to consult Voc Rehab, get the list. There's CMS is a federal program. So when I needed help, I had to reach up to the federal level to get it. And it's like these hotkeys on your keyboard to make it read through a specific website. So it would read the platform to me. Now we got Windows. So if you have Google open and then you have Microsoft Edge open, go ahead and right click in your Microsoft Edge and it'll say read aloud, and it'll read
I love
anything.
that
Anything.
tool.
Google, no. Google's not
Yeah.
accessible. When we look at healthcare, like I log in for my daughter's healthcare stuff, Banner Health can't even teach me how to log in. There's an issue there with providers. So I don't know. I just feel like it's cheaper to customize for the person and let the businesses off the hook a little and just, you know, bring them up to standard, but really support the person individually. And then we have some cultural issues too, right?
Yeah.
With the language.
So I think that sorry, I I use all those tools myself, and I do not necessarily need accommodations, but it makes me much more likely to succeed, right? And I think everybody can have access, and that way no one has to identify that they're needing access, right? Because that's another
I want everybody
point
to
of
pass.
Yeah, and not everybody is comfortable admitting that they have a need for accommodation, and they don't have to go to a doctor to be able to ask for one, right? Like I feel that there is prevention that, like, oh, you know, if you get into your wellness visit, sometimes there is a need that you need a note from your doctor. I've had that so many times, and I was like, it's clear to me, and why should I be the one to actually give that to you when you can identify it yourself? But I think that is a tool to getting people in for prevention, is creating that understanding that that can be also an advocate for you as a provider, and the practice to first get maybe access, hopefully, if we as you know, maybe the Ray can help direct them to this tool. But I also think I had a lot of triggering during this disabilities meeting yesterday, because they were saying that the providers are not trying to learn how to work with people with those disabilities. But what I actually encountered was I was very interested in using all those tools. My practice stopped me and actually kind of pushed me down and told me stop complaining when I would advocate for my patients to have better accessibility.
You know, and our doctors are like, and our nurses and stuff, they're
it.
like school teachers. Like they're already overwhelmed. They're already busting their butts. They took a lot of education. And honestly, they're going to compete with AI, and hopefully they're using AI, because AI does a great job of diagnosis. And how can one human
November, so. Oh, here's Dina, just in time.
Okay, had a question?
Yes, we do.
I do, but go ahead.
Please, no. I'm just glad she's here.
Yes, delighted. How high level do you want these recommendations? I mean, do you want very global recommendations, or do you want something more strategic? That's where I'm struggling.
I'm thinking something where it's something that we could implement at the department. So something at the level of something actionable that we can actually take into and put into place here at the department. If that helps.
So, okay, so what I'm thinking is just how to empower community health workers that are working in this space, like doulas and midwives of color. And, you know, so I'm thinking of some models around the country where health teams are inviting doulas to work with obstetricians, et cetera, and they're getting great health outcomes in other states. And so how could we possibly do this in Colorado is what I'm wondering. And so the larger question is creating this bridge between community health work and corporate health. And, you know, how do you create financing structures to support community health workers, doulas, midwives, et cetera, so that they are partners on healthcare teams and they're able to function and do their great work that isn't necessarily occurring within a health system, or maybe it could occur within a health system, but the culture of the health system would have to change.
No, and I think, you know, putting something in place or recommending something to that effect, and then we'll just have to maybe work on those finite details on how to make it happen. But to say, you know, these doulas and the midwives need to be part of the health team. They should be included, is, you know, coming out of this group is the recommendation, you know, and then it'll be up to, you know, the department, and then we'll bring in, you know, we can bring you back in to help us figure out how to make that work, you know, and then we'll, you know, there's of course all the money piece, but you know, the idea is to make that's what you're recommending from this group, is to have those doulas as part of the health team. And maybe, you know, it's something we put in, you know, when with on the providers, do you have a doula on staff? Do you have, you know,
Exactly.
Right. You know, it's
Right.
part of their
Standard operating procedures.
and that's part of, you know, on their list that they have to have a doula on staff.
Exactly.
So, you know, something on that level, and then I think we can kind of go forth from there within the department to figure out how to make that work.
Okay.
Did that help?
Yes.
Okay.
Thank you. So I wrote support reimbursement that would allow the expansion of care teams that provide culturally competent care for the well-being of perinatal patients. Maybe?
Can you say that again, please?
Sure. Support reimbursement that would allow the expansion of care teams to provide culturally competent care for the well-being of perinatal patients.
So Mike,
such as excuse me, I've been losing my voice. It's called Script Talk, and it's called Accessible RX or whatever. And what it is it's being able to read your bottle, your prescription bottle, being able to know when your refills are, knowing what the dosage is, those kind of things that are not easily done for someone who is blind. There's you have to request it, and depending on if the pharmacy has chosen to be a part of that, depends on if you'll even get that. Because I guess it costs a little bit for the pharmacy to do it. I think it would be great if it was just an automatic thing that was already paid for through Medicaid, so that you could have that access. You know, I get it here because I requested it, you know, but it's not readily available everywhere. And it's not readily available if there's another pharmacy within, oh gosh, I want to say 50 miles, which makes no sense to me, because not all pharmacies work with Medicaid. So I just think that's something else that is a barrier to some people that can't see or have difficult in reading, dyslexia, whatever it might be, reading disability of some sort. That should be available for everyone that needs it, not and at any pharmacy that is accepted by Medicaid. And that's something that could be done from the top down instead of from the pharmacy.
Fantastic. And it's so dangerous to take a wrong medication or the wrong dose. So
Very much
dangerous.
so. Yep.
This is a
So-
much needed service.
I know we've talked about a lot of different things over the last however many months, but I wonder if this is something that we can, I think part of what I'm backing up is like, we've talked about so much over the last few months or like 6, whatever long we've been doing this.
Could be, there's lots of other things going on, but giving people full range of spectrum of choice in some of these decisions, it just is a really delicate balance with some of these providers, because you also we want to support these practices that are doing the best they can in really underserved areas. But it's just a really key, to me, it highlights a key difficulty in our health equity conversation. And I think Julissa has experience really going in, working in some of these communities, working hand in hand with providers. And that's where I do think cultural validation training has really helped them, when it's not just an online mandatory training, but it's like a person, it's a team, it's a community. It's not really seen as, okay, can you go on to your online training platform and check this box, but can we work with you around what are the options, what are the real barriers, what's really going on in the community, and what are some of the community members saying that they want or can't get, that we can help them get access to.
About their, for example.
Yeah, thank you. We are working with a lot of new immigrants, and we are learning a lot of things of the support for new people that have been in the States sometime less than 2 days, and how to connect them to the different systems. For us, has been a learning process. For me, that I have been helping directly and taking out my leadership role to be more of the liaison, has been challenged, difficult, but at the same time, helping families, it's amazing. Yeah, and we work with families with children with special needs and disabilities, and we're seeing more and more severe multiple disabilities, kiddos that they have not been receiving therapy.
I don't know if it's been a part of the conversation, and especially that we have your ear today, Dr. Walsh. I'm just plugging in some key conversation pieces that we've been talking about in this group. It also dawned on me too, when we talk about cultural validation trainings, again, I think that there's a wide range of variance, and also, when you have high quality trainers, training can be a lot more meaningful and can change hearts and minds in ways that more poor quality training can't, or like we're talking about, even just required checkbox training. And so I also wonder if there's a way, as we talk about incentives, incentivizing trainings or whatnot, I wonder if there's also a way to ensure we can pay for high quality training, or if there's a way, again, you're talking about malpractice insurance, but when we talk about like the financing vehicles for some of this work, putting money into helping, like, again, Julissa has such great training materials and people, if she can train more people, promotores in those communities, if we can pay for people in the community to help do training, if there's a way we could finance some of that to get high quality training in these offices, not just an online module.
I heard what you said. I'm gonna bring it up with Aaron. I'm not sure how to effectuate it. You know, there's almost always a way if you have a good plan. And the point is, we do get support for key programs when we have good plans. And so I think that's possible. Okay, but I think we need to figure out how to actually do what you're recommending.
Totally.
Makes sense.
Yeah, I agree.
We have about 15 seconds and then everyone will come back into the main room.
Okay, we're going back to the main room, Jen. Okay.
I think we might all be back. And I just had a question for everyone. It seemed like all the groups were doing good work and had some great conversations. Did you need more time? Would you like more time? Or did you get some things accomplished and you're kind of in a good spot right now?
Maybe at least 5 more minutes.
I
We're
think
supposed to be writing it up on the Jamboard.
whatever your group you can within your group, you can use the Jamboard, you can start working on that recommendation form. So whatever work is working for your group, I would use. So I can add some more time. Maybe. If it'll let me. We have a little time on our agenda that I think we're okay if we extend. So I'm gonna open the rooms back up. And it may, I'm not sure the time frame it's gonna give us. It's gonna put another 30 minutes. And I think we'll go with that and see, because that'll take us to about 10:45 and then we can kind of wrap up there. So again, you can go back to your rooms, kind of finish up some of your work on your recommendations, continue to brainstorm and kind of finalize some of those recommendations. And we'll come back right about 10:45. And again, the main room will be for vaccinations. Room 1 is maternity. Room 2, access to care. Room 3, behavioral health. And room 4, prevention.
Dana, quick question. I
Yes.
have the recommendation form pulled up, but it's not, maybe I have to, I don't know if I have to sign in, but it's not letting me write into it.
Oh, let me see if I can do the access. And which group are you in?
The COVID group.
Okay, let me at least open it up for, let me see if I can do that. It should be able to work now, hopefully. Let me know if it doesn't, try something else.
I mean, it's letting me download it, but it probably won't save to the drive though that way.
Huh,
Is anyone having an issue?
let me specifically, if I can just give you specific access, because I have it to where, if you have the link, you should be able to. Okay. So I gave you editing access, so let me know if that works.
For some reason, it's still not working for me. Can someone else try and see? I mean, I'm able to access the
Same here.
document, but there's no way
But
to
you
edit.
can't edit into it. You can't.
Yeah. Sorry, what'd you say, Jason?
Same here.
Same, interesting. All the other documents, are they the same way, or is it just this one that's giving you problems?
Yeah, I'm able to edit the Jamboard, and then same thing with the work group focus area document. I'm not able to edit that. So it seems like it's like the Word document.
The Word document. Oh, interesting. Oh, I'll have to figure that out. If you could maybe take notes somewhere else.
Yeah, I was able to download it, so I can just save
Okay.
it to my desktop and then maybe send it to you later if that works.
Okay, that's perfect. I'm
Okay.
sorry about that.
No worries. Thank you, Dana.
Uh-huh.
So do we want to put cultural validation training?
About Medicaid, some of them, we need something to that they take care, like radical self-care. And let's see, I told my team, if it's a success, it's El Grupo Vida. If it's something that go down, it's my fault.
Spoken like a true leader. That's good.
Going back to the health literacy topic, I also think that I hear a lot about people in materials or other ways of letting people know what services are available. The system is just so complicated. There's so many parts to it that I feel like that's sort of unfair to ask people to learn about all that. And I would rather that we had really great things like support groups or care coordination or case management, so that people didn't have to be experts in it and could get help navigating.
if that's easier, or we can
Okay.
chat on the 6th too. Since that's really not that far away, I'm realizing.
Yeah, that's true. We
September's
can
almost
chat on the
over.
6th. Yeah, we can chat on the 6th to see if we need another meeting.
Okay, that sounds good.
Yeah. And we have this sheet, the Jamboards, the notes on the Jamboards, and then there's also a Word document. And then the notes that we took from this meeting, where should they go?
So I just was typing on the which I think there's like meetings that are missing here, but I think we then use the Jamboard. So it's the document titled work.
It's mostly folks that are already that are complex, that are already engaged in the system. So I feel like it's in terms of being more upstream, where you could help folks navigate this highly complex system, and wait lists. It's like, where do you even find someone who can see you? And never mind if it's culturally tailored. Before you're like ending up in an acute emergency situation, it's hard to have the resources for that. But I know that we really want to up our game around helping folks have that health literacy, understanding the system. But what's that point at which, like, why should you have to understand this crazy convoluted thing? Let me help you understand to a point, and then just call this number, and there's going to be a guide here who's going to help sort of walk with you to figure out the best place to plug in, or what services might be best for you and your family. I didn't have an idea in there. I was just
No, and I appreciate that.
I like it.
Yeah.
No, I remember what we are doing with Medicaid, having focus group that is not just only translating material, but also that the family really understand what is going on, and has been amazing. Like, it's unbelievable all the information that family has been telling. In that case, what do, like, if we have media or promotion or something, not just only translation, but also connect with the families to see, do you understand what's the meaning of this? Do you think that this information is valid? Do you know which place you need to go? Because it's really hard when a family is desperate, needs support, and we give a number, and this happened to me with a family, and then they don't have interpreters. And again, I know we're not talking about interpreter, but they don't have, or they have somebody that have a broken Spanish. That it's fine, it's important too, but they are not understanding or tuned to with what is going on. And yeah, how can we connect? How the families know when they need to receive services, which services are free of charge, or which services they're going to receive a bill, because we are still having these issues of receiving bills, and parents are really concerned and afraid to request help because they don't know which one they are going to receive it or not.
Yeah, sort of a gotcha moment, right? Where then they're on the hook for something. Yeah. Right.
I also think like a statewide campaign about the availability of behavioral health services might be helpful at some point. Something like with billboards, really big news, because I
Yeah.
still talk to people regularly who don't know that Medicaid covers behavioral health.
Yeah. Right.
It's just not, so depending on where you live, I mean, where you may not have a mental health provider near you, behavior or SUD provider near you, then as far as you know, it's not there. So, yeah.
There is it's not quite the same, but reminded me of there's a group in the metro area. So this is, very specific to the Denver area, but of like a consortium of the local public health agencies and the major hospital systems and the RAIs, Socorro Access, but also CCHA there on the west side of the metro area, all come together. And one of the priority areas of work was to do a joint sort of stigma reduction campaign, because every hospital that has to go sort of do their nonprofit hospital has to do a needs assessment, and every local public health agency, they all come back with mental health as a priority, right? And so if everybody's sort of doing their own thing versus coming together and having like joint campaigns and messaging, I think it's good in theory. I don't know. I don't know how effective it's been, but kind of intended to be sort of bigger or sort of, media outlets. And I don't know if they had billboards, but that concept, like if we're all at least using some of the same messaging, maybe it'll I don't know, be more effective, maybe.
Well, and the other side is when it's a crisis, a person enters to a mental health facility, the process. Because most of the time it's a very individual process instead of a collective process. I sadly I had that experience and was really awful because they are like, no, people go individually instead of no, this is a collective, this is a family member, and treat as a collective. And this is one of the things that I feel it's missing because you are receiving support, but also you are receiving trauma through the system because this is the rules. The rule is we're going to take the person 24 hours because we don't know what the heck is happening. And if the person provides permission to you, you will have the right to, and it's hard. Like I can again, I have still, this was 10 years ago, but I have still PTSD of that experience with a hospital that I was like, okay, what do I need to do to go inside that place to support? And again, it's like, how do we connect? Do we, like when the family finish our services, are they feel like was a blessing or a good experience, or was so awful that they are not going to request support anymore because the thing was they took somebody else that I'm helping from me.
Okay, going back to the main session, Jen. Yep, you
Okay, I think we're all back. Hope that extra time gave you guys just some more time to kind of wrap up some things and finish out some conversations you had started. So now I think what we'll do is just do a quick report out from each of the groups. Just kind of let us know some of the discussion items you guys were talking about and some interesting things that may have come up that you would like to share with their larger group. So I will start with the vaccinations group.
Can you all hear me?
Yes.
Hello, Kaylin Chandler here, presenting from the vaccinations group. And Sophia, you can jump in if I miss anything. We're putting together our recommendations. Today, our conversation was really focused on two of our recommendations, which one is really centered around cultural validation training, and especially figuring out a way to either incentivize providers to complete these trainings or pay for high quality trainings and people to go out and do in-person trainings. It's a little bit of a nuanced recommendation because, again, we don't want to just make it be a checkbox for providers or a barrier ultimately to provider enrollment for Medicaid services. So we had a lot of conversation around how do we incentivize it versus making it potentially a requirement, or what's the benefits, pros and cons of either way, and then also looking at other malpractice insurers across the state potentially pursuing it through other routes, but again, realizing that cultural validation training is a very important first step to working on health equity work. The second recommendation our group focused on discussing today was around reimbursing community health workers, promotores, and what that looks like. So I don't know, Sophia, if you want to add anything.
No, I think you covered it well. Thank you.
Okay, thank you. So next we'll go to the maternity group. And I'm not sure if anyone is still on from that group. They may have had to leave because I'm not seeing anybody that was in that group. So then we'll jump to the access to care group.
Thanks, Dana. We talked a lot about utilizing AI for health literacy and accessibility for all of our members. And so that conversation kind of spun into a recommendation just of how can we utilize these platforms and these apps to help increase access to care. And so really talk through the available apps, standards that are available, and kind of doing an environmental scan of the state to really understand what organizations are using which platforms and what's good and what's bad and how can we improve that. So that was a big piece of what we chatted about. On my group, please jump in if I have missed anything from that.
Okay, thank you. Let's see, behavioral health.
Hi, I was nominated to speak here, Bethany Prey. Our recommendations were very focused really on in-person contacts with to enhance people's experience in behavioral health. So first, expand pathways for people with lived experience and or language abilities to join the workforce, and working with the Office of New Americans or groups like the Spring Institute to do that effectively. Second, increase compensation for those people with lived experience and or language abilities that recognizes the expertise they bring, and recognition that compensation is currently not adequate for those skill sets, typically. Separately, compensate appropriately for interpretation in behavioral health, recognizing that services when you're using interpretation and talk therapy, those services take a lot longer. We also recommended creating formats for therapeutic services or supports that are culturally appropriate. For cultural reasons, not all people will benefit from one-on-one therapy, for example. So listening to families and individuals about what would work for them is the right place to start. On the health literacy front, we had a few suggestions. One is considering a broad coordinated campaign with providers, hospitals, local public health, and the state that uses consistent messaging about stigma and what is available to Coloradans in the behavioral health sphere. Also increasing the ability to provide a lighter level of care coordination to more people, because we want people to be able to get help navigating the system before they have acute needs. And last, providing training or information on behavioral health more broadly so that people know what to expect when encountering the system and can provide feedback on making those interactions less traumatizing or isolating, because those negative experiences also add to stigma going forward. And I think that's it for us, but I hope both will jump in and add.
Okay, sounds great. Thanks for sharing. And then our last group is prevention group.
I mean, I'm more than happy to share. I think we did a lot of discussion around just kind of well, we were listening to Jeanette. She's a person with lived experience that has a great amount of advice and tips. So I think we were trying to leverage that. But in the long run, I think some of the recommendations we had were names of entities and services can be changed to more plain language and member-centric terms. So even Ray, like all of the HCPF terms of like what services and navigation entities, you know, they're not clearly intuitive to understand what they are. And so using them, I think, creates a literacy issue. All forms can have travel with a patient. So if you're doing the PCAP or the application for Medicaid, you know, there is a way to already identify what accommodations you need from the get-go. And then if there are more identified, I mean, just be able to follow the patient so that, you know, it can be identified either way and it's not this constant request. Module training and roundtables around services and navigation that can be offered on patient time, you know, when they want to learn. I'm at the public health in the Rockies conference today, and I passed by the School of Public Health. They have a Latin policy and research team, and they had a bunch of flyers on community roundtables on how to navigate healthcare. So again, just like setting people up for success, improving the baseline of knowledge. And you know, that's just consistent across the entire state of how things go. And then the engagement, language, and other accessibility filters for provider search on the website. So the Health First, you can't actually filter for language. Quite honestly, as a provider and somebody who had to place people and in transition, and sorry, ASL to interpreter, I apologize for not talking slower. The tool itself is not reliable, even taking new patients, but also there's no way for us to be able to filter for, you know, people who are needing more culturally, you know, and, you know, member-centric providers. And then one thing that we actually identified was that Microsoft Edge, which I highly recommend, has a tool where all PDFs you can have read aloud and in any language you want. So that is another way around the long run of this requirement to have more accessible intake and like experiences through virtual stuff. But that can also be something HCPF can recommend for people to use, but also that those tools be used more frequently. So like Google, may not be as accessible of a tool to be providing, this public engagement committee stuff versus obviously Zoom. So those were some
Sarah,
of the.
I know that we were in the same group and we talked a little bit about that. With Microsoft Edge, does it also translate into other languages?
Yeah, I think it can.
So that will read aloud. Okay. Yeah, and I think just that simple education to redirect members, providers to use that search engine versus Google would expand a lot. I don't think that I've ever seen that written anywhere. Like, we recommend you use Microsoft Edge. So that would be something.
Yeah. And that was pretty much as we got, but I would say from prevention, I think it's about understanding what is prevention, and then in the long run, I think there's some Ray level stuff that we came up with too, actually. So thanks.
Thank you. Thanks,
And
everyone.
just as an information, Dana, there is a health literacy conference on October 20th that would be a great resource for people. I know that we will be going because we always want to learn best practices with health literacy, but advertising more of those kind of resources as well, and even providing more health literacy task force, within HCPF would be great.
And Lynn, do you have that information on the conference on October 20th?
Yeah, let me go ahead
and
let me pull up the flyer and I'll send it your way, Dana, and you can send it to other people. How's that?
Okay, that's perfect. Thank you.
And that
Yep,
organization
you bet.
holds a lot of stuff. Also, I've been part of that organization for quite a while, and it's startup, and they're starting to become like the subject matter expert or the gold standard. And also libraries quite often are really participating in that space. So I've been very happy with it. I definitely think health literacy training among internal staff and the Ray is super, it's just gonna catch us up a lot faster to creating tools that, like, we already automatically know whether or not it's somewhat health literate because we've already been taught to identify where things aren't.
Thank you. I think for kind of our last bit, we'll just kind of open it up to any comments or things anyone wants to share. I just want to remind everyone about the ACC concept paper that Katie shared. The link should still be in the chat. And then the upcoming stakeholder meetings that they're holding, and the ability to add your comments for the concept paper. So just kind of reminder on that. And then I'll just open it up if anyone has any other comments they'd like to share, or any upcoming events or anything else that would be good for the group.
Hi, this is Kelly Shanahan. Just a real quick question to Sarah and Lynn, who were just mentioning that conference, and you, Sarah, you said this agency is really becoming the gold standard. Can you say again who they are, what their name is? Oh, you're muted.
It's the Colorado Health Literacy Coalition.
Oh, there's a Colorado one? Okay, cool. There is a national one too.
Yeah. Yeah, no, this is a Colorado one. And like I said, it's October 20th. I sent the information to Dana. It is from 9 to 4 up in Denver. And I've been to a couple of these before. They're excellent. I mean, I think that everyone, care coordinators, would benefit from attending conferences, health providers, because it gives you practical tips of how to write things in ways that members understand, which is all about preventative care. It's all about advancing immunizations, maternal care, making things are easy to understand.
Oh,
Yeah.
great. And what
I didn't know the Colorado one, so yes.
What I'll do is I'll make sure I send it out to the group. I'll send a email with the flyer. So thank you, Lynn. So I'll make sure everybody has that information. And Jeanette, you had your hand up.
Yes, thank you. I talked to my neighbor and they're intersex, and they would like this as an identifier because they're born intersex. A lot of kids are born intersex and don't even really know it. I don't know, the providers know what to do with that and maybe make some suggestions to pick a gender kind of thing. But they did ask me to carry their voice to places where they might not attend and have intersex placed on applications. And then I did work on a child welfare board where we're looking at kids who are closed cases or leaving the system but going into schools. And one of the things that really was on my heart was, if a kid gets diagnosed, can we offer that testing for the parents too? Thank you.
Thank you. Great points. Any other comments or anything else anyone wants to share? And if not, I think that will do it for our meeting today. I thank you all for joining us, and I thank you for engaging and having the conversations today. So I want everyone to have a great weekend and enjoy the nice weather. So we'll talk soon. Look for emails. I'll send information out on that October 20th. And then I'll probably share the links again for the ACC concept paper and their public meetings. But again, thanks for attending today and have a great weekend. We'll talk to you soon.
Thank you. This meeting really warmed my heart.
I'm good.
Have a great weekend.
You too. Bye-bye.
Bye.